Welcome to this clinical lecture. Today, we are exploring a comprehensive neurophysiological framework designed by Assistant Professor Dr. Farhad Mustafa Musa Atrushi. Neurophysiology functions as an objective electrical multimeter. It allows the surgeon to quantify injury severity, pinpoint anatomical localization, and establish a clear clinical prognosis. In modern orthopedic practice, overlapping comorbidities often obscure the primary surgical target. This diagram contrasts an acute focal emergency, like an L5 radiculopathy, with the chronic background noise of diabetic polyneuropathy. Electrical signatures isolate the acute segmental denervation from generalized systemic decline. Standard physical examinations and MRI sequences often lack the resolution to separate these overlapping conditions. Imaging captures anatomy, but it cannot measure real-time functional distress or active signal disruption. Without precise electrical isolation, surgeons risk operating on anatomical anomalies found on scans that may not be the actual physiological source of the patient's deficit. Locating a deficit requires an analysis of the peripheral hardware. This cross-section shows the basic functional unit, the inner axon acting as the electrical conductor, surrounded by the myelin sheath providing the insulation. The presence of myelin dictates signal velocity. Large myelinated fibers enable rapid conduction, while small unmyelinated fibers rely on slower conduction. The set-in classification maps nerve failure. Grade 1, neuropraxia. Myelin damage causes conduction block. The axon remains intact. Grade 2, axonomesis. The broken axon triggers Wallerian degeneration, but connective pathways survive. Grade 3, neuromesis. Complete severing of all structures, destroying the pathway for spontaneous reinnervation. Grading this structural failure dictates the core surgical decision, whether to wait for guided spontaneous axonal recovery or to intervene immediately to restore anatomical continuity. Measuring these failure grades in vivo requires a diagnostic arsenal of nerve conduction studies, electromyography, and evoked potentials. Nerve conduction studies, or NCS, gather two metrics. Velocity measures myelin health, slower speeds indicate demyelination. Amplitude estimates surviving axons, a drop confirms axonal death. For proximal segments, the F wave forces the signal to the ventral horn and back, evaluating polyradicular syndromes. Electromyography, or EMG, analyzes muscle fiber activity. Pathological denervation shifts the baseline from a dense interference pattern to reduced recruitment and large polyphasic waves. This is driven by motor unit rarefaction. Surviving neurons adapt orphaned fibers, creating fewer, significantly enlarged neurogenic units. This matrix maps the combined NCS and EMG results back to the set-in classification. Conduction blocks signal neuropraxia, while pathological spontaneous activity on EMG confirms axonal disruption. The NCS assesses the structural integrity of the anatomical highway, while the EMG measures the functional distress at the muscular destination. Together, they provide a topographical map of the nerve injury. The dorsal root ganglion is the sensory metabolic center. In preganglionic lesions, damage is proximal to the DRG. The distal axon survives, preserving the sensory nerve action potential, or SNAP. In postganglionic lesions, distal damage cuts off support, causing Wallerian degeneration and an absent SNAP. This electrical binary, a preserved versus an absent sensory action potential, is the standard separating an untreatable nerve root avulsion from a potentially repairable peripheral plexus injury. Shifting into the central nervous system, this cross-section reveals the spinal cord's ascending and descending highways. Motor evoked potentials, or MEPs, test the descending lateral corticospinal tract, while somatosensory evoked potentials, or SSEPs, test the ascending dorsal columns. However, centromedullary lesions like syringomyelia create a diagnostic gap. Peripheral MEPs and SSEPs bypass central damage, returning a false normal. The solution is contact heat evoked potentials, or CHEP. Testing the spinal thalamic tract, CHEP is highly sensitive, routing directly through the lesion center. Relying strictly on routine modalities for complex central lesions will result in misdiagnoses. The surgeon must select the specific test that physically crosses the suspected anatomical damage zone. Integrating these diagnostic findings allows for the precise differentiation of the three primary spinal cord syndromes. In anterior cord syndrome, the dorsal columns are intact, so SSCPs are preserved, but the anterior damage abolishes both the MEPs and the CHEPs. We contrast this with posterior cord syndrome and Brown-Séquard syndrome. Neurophysiology precisely maps the affected quadrant of ischemia or trauma. We can now trace the diagnostic journey from a single peripheral nerve fascicle up to the total spinal pathway. These electrical metrics provide actionable data. They allow surgeons to detect structural damage and identify nascent axonal reinnervation long before these changes are evident on a clinical exam. Mastering these neurophysiological principles provides the functional context required to separate static anatomical findings from active physiological deficits. We extend our formal gratitude to Assistant Professor Dr. Farhad Mustafa Musa Atrushi, MD, Board of Certification in Orthopedic Surgery, for authoring the frameworks that make this precise clinical intervention possible.